It's my great pleasure to be here, and I greatly thank Professor Kazam for inviting me to this exciting meeting. This session is focused in the remodeling of the heart, and as the first speaker of this session, I'll review the ischemic remodeling after myocardial infarction. As you know, the infarction make a kinetic region. That means doesn't work here. Then, over time, the scar formation fix the non-infarcted area. However, the other remaining non-infarcted area has responded, even in the hypertrophy or the dilatation of the heart. This response is very good for the maintaining cardiac output in the short term, but in the long term, it is very harmful for the prognosis of the patient. The most important issue in the ischemic remodeling is that the intensity or extent of the LV remodeling is closely correlated with the prognosis of the patient. So ejection fractions is decreased here, and the diastolic volumes increase, and infarct segment length increase, very clearly correlated with the prognosis of the patients. So remodeling is the surrogate marker for the patients with the following myocardial infarction. And to look at the process is, I said, the stepwise process of LV remodeling from the very early time to the months or more. Onset of MI is caused ischemia, and some part is the necrosis, and another part is the apoptosis of the cell death. Within one or several hours, inflammatory response is occurred. This is triggered by reactive oxygen species, and pro-inflammatory cytokines is induced, and this is good for the wound feeding process. And one day, several mobilization, neutrophil, macrophages, or lymphocyte is mobilized from the bone marrow and emerges in the peripheral blood. And within a couple of days, extra cardiac ECM, that means collagen degradation occurred by metalloproteinase secretion or granular tissue formation. And within 1 week, this ECM remodeling occurs by collagen synthesis and neovascularization. And 1 month is fixed with the LV modeling, scar formation, and finally LV dilatation. And in some part, myocardial hypertrophy is responded to make a final stage of the ventricular modeling. So we have to think about and consider each steps, many players involved. So this is a surrogate marker of the prognosis, but how to treat the heart or how to treat the patients is very critical, time independent. And this is the infarct extension, ischemic necrosis, apoptosis. And this stage, deep perfusion, is the most important, either by PCI thrombolysis. So the blood supply is very important to reduce the LV remodeling. And also the anti-apoptotic therapy, that means I touch the adenosine or KATP channel opener or mineralocorticoid MR blocker is also the very key factors to reduce the apoptosis. And look at this slide. This is the infarct size, and this is the timing on reperfusion. And myocardial infarction patients, within 3 hours, if we succeeded to reopen the coronary artery, infarct size is reduced However, after 3 hours or 3 to 6 hours or even more, the infarct size is not reduced. That means the very early reperfusion is very important to squeeze the infarct size. However, in a late stage, that means 1 month or 20 months later, EDV is the volume of the left ventricle is the same even within the 3 hours reperfusion or even 24 hours reperfusion here. And after that, the later phase, left ventricular volume is increased. That means a critical time to reduce the infarct size and to reduce the LV remodeling is different. So we have to consider that even late reperfusion is very important to reduce the LV remodeling of the heart. So the 24 hours after the onset of the infarction is very critical time. And after that, what happened in the remote or borderline area? And this is 1 day in myocardial infarction area. This is border zone, and this is remote. So in early days, the apoptosis, myocardial apoptosis, expand to the peripheral regions. 1 week later, this is the border zone and remote area. Many myocardial site is died from apoptosis. 12 weeks later, most of the apoptosis occurred in remote area, non-infarcted area. That means no ischemic area, apoptosis occurred in a later phase. And this is the correlation with the fast ligand and fast expression and LV wall stress or LV-EDP. And remote area, no ischemia. However, the reactive oxygen species activated apoptosis process. So in a remote area, apoptosis is occurred depend on the wall stress increase. So the wall stress is a bad trigger for the apoptosis in a remote area. If it is the case, the adenosine is a key molecule which opens the K-ATP channel. And as you know, the adenosine is an ATP degradation and is very potent vasodilators. So may be effective in the early phase of acute myocardial infarction. It's open the coronary artery and also it inhibits apoptosis by K-ATP channel. And some trial was conducted as Amistad 2 trial. And this is included 2,000 anterior myocardial infarction in the acute phase and give the adenosine 50 microgram or 70 micrograms in the acute phase after deperfusion. And infarct size with a larger dose of the 70 microgram, infarct size in comparison with placebo is decreased. And this is the infarct size here and the composite endpoint that may death or hospital heart failure or rehospitalization. This composite endpoint positive patient is a higher infarct size. So the decreasing infarct size are good for the patients to reduce the endpoint. Recently, the open AMI trial was conducted and reported last year and this year. And this is after the thrombolysis aspiration, and they give the adenosine intracoronary in the infarct-related artery. And see what happened, ST segment revolution and also the angiographic microvascular obstructions. And here, this is adenosine, this is nitroprusside, and this is the saline as a control of the placebo. And you can see the revolution of a ST segment elevation is higher in adenosine group. And also this year they published the prognosis of the patients. And this is adenosine, this is the nitroprusside, this is the saline placebo. And you can see the adenosine is significantly improve the prognosis of the patients. And in this study, the LV remodeling is not measured, but we easily expect the remodeling is attenuated by the intracoronary infusion of adenosine. And another key factor in the acute phase is the spironolactone, is the mineralocorticoid receptor blocker. And there is a report that AOR receptors is increased even in the early phase of the myocardial infarction. And aldosterone is the incorporated in the heart in the early phase of the after the myocardial infarction. So this study is done in patients with anterior acute myocardial infarction and LVEF, EDV, and ESV by giving the spironolactone 25 milligram per day. And this MR blocker increase ejection fraction and decrease the endodiastolic volume and the systolic volume, and also spironolactone decreased procollagen type 3 amino terminal peptide. This is the biomarker of the collagen synthesis. So this is a very clear correlation with the this biomarker and also the EDV. So the early administration of spironolactone reduce the LV remodeling. So after these hours or days, myeloid cell recruitment and necrotissue tissue resorptions and ECM degradation, granulation tissue formation. In this phase, immunomodulation or RAS inhibition or stem therapy might be improve the LV remodeling. So the candidate of the player is cytokine inhibitor, inhibitor ERV or MR blocker, or the Gcsf to mobilize, enhance the mobilization of a neutrophil or progenitor epithelial cell and bone marrow derived stem cells. And how about the TNF alpha inhibition in the inpatient myocardial infarction? There is no clinical trial. However, in the severe heart failure, the renewal study is the etanercept. This is the recombinant human TNF-alpha receptor antagonist. And this is the actually no significant difference from the control. However, in this phase, in the 3 to 6 months after the administration, LV ejection fraction is increased and LV volume is somewhat attenuated. So it might be possible to have some effect, but in total, there is no significant difference. And there is a report that after 7 days after onset infarction, this is the endothelial progenitor cell is mobilized from the bone marrow cell. So day 7 is a peak. And there is another report that mobilization enhancement activation reduce the infarct size and reduce the remodeling. So after that, Gcsf is a stimulator of the mobilization of these myeloid cells, and many trials have done. And this is the meta-analysis, but it is not significant improvement, but somewhat ejection fraction is increased by Gcsf treatment. So it is still controversial, and we have to further trial the timing, what dose of the Gcsf, what the combination of another another drug or something like that. So some modification is necessary to improve the, and another candidate is the inhibition of the metalloproteinase. Metalloproteinase is, the degradation of ECM, and there is a couple of trials. This is the MMP inhibitor, GP11680, is elevated remodeling after myocardial infarction. Unfortunately, this trial failed. Thus, LVEDV and also day 90 change in the LVEDP is not different. This we call the premier trial failed that MMP inhibitor. But metalloproteinase inhibitor, we have 25 species. It's a big family. So what type is a key molecule which inhibit the LV remodeling is not still unknown. So we have to further trial what types of MMP should be inhibited to reduce the LV remodeling or not. And this is another interesting that epinephrine is also the AOR inhibitors. Ephesus trial, as you know, the AMI trial, 6,000 people, reduced the cumulative incidence of the mortality and heart failure. However, interesting is that if the epinephrine started within the early phase, before 7 days after the onset, it is effective. But if we start after 7 days, then it is not effective. That means the timing of the initiation of the drug is very important to determine the LV remodeling. And we have to think about more reactive oxygen species is a key factors. And these angiotensins, catecholamine or cytokines, is the activate NADPH oxidase is a source of reactive oxygen species, and reactive oxygen species are the modified EC coupling and modified contractility and cardiomyocyte cell death and extracellular matrix remodeling or production pro-inflammatory cytokines. So how to manipulate the ROS is very important. And we found the novel signaling pathway, and this is the angiotensin stimulate GPCR and increase the calcium and activate the LAC. LAC activate incorporated in NADPH oxidase, and this causes reactive oxygen species. And the downstream of this signal pathway, we found ASK1, that means apoptosis signal kinase 1 is activated. This is a key factor of the JANK and P38 activation. And finally, NF-kappa B, this is the transactional factors which stimulate the cytokines. Inflammatory cytokines pathway is in the upper loop is angiotensin 2 or catecholamines or endothelin 1. These factors is activated this pathway. And if we ablate ASK1 knockout, then myocardial infarction in that is you see this is the wild type ASK1 knockout, and this is a much improvement to cause the heart failure in the rat model. So ASK1 knockout is very important. However, we do not have any drugs which mimic the ASK1 knockout. So if we have lucky to find a small molecule, this might be the candidate of the treatment. And finally, late stage is a scar formation, reactive fibrosis, myocyte hypertrophy, dilatation, erythrogenesis, heart failure. In these processes, ACE inhibitor, ARB, MR blocker, beta blocker, statin, stem cell, or microRNA might be involved in to reduce the. And finally, I showed that a couple of slides that this is the ACE inhibitors for treatment of the patient of acute myocardial infarction. Early administration, that means 48 hours within 48 hours after the onset of the myocardial infarction. This is after 48 hours. See that odds ratio, 1 month, 6 months, 12 months. Early administration and late administration is better than the odds ratio. That means ACE inhibitor is not necessarily the early administration. Even the late administration, the continue for a long time is better for the improvement of the remodeling. How about beta blocker? Beta blocker, as you know, this is also the reverse remodeling. Is a very good drug, and even the beta blockers, carvedilol and metoprolol, have this is meta-analysis conducted by PACRA. Is some difference in a drug, and the actual the reason is not completely known yet, but it's some difference between the beta blockers. Maybe discussed later. And finally, again, I show you that the stepwise process. Onset of myocardial infarction within hours, and 1 day cellular mobilization, 2 or 3 days ECM degradation, 1 week remodeling, and 1 month the final stage of LV remodeling and scar formation LV dilatation. So this is the last slide. Cardiac remodeling following ischemic event is a stepwise process involving cardiomyocyte, myeloid cell, ECM. A number of key players contribute to the remodeling process. Cell death, reactive oxygen species, inflammatory cytokines, myeloid cells, metalloproteinase, TIM, fibroblasts, collagen, neovascularization. Action of these players are time-dependent, interact with each other, forming a dynamic network. Appropriate treatment for cardiac remodeling should be projected to the unfavorable intrinsic response to the ischemic insult and subsequent change in the heart. Thank you very much for your attention.
Thank you very much, Professor Hori. So, are there any questions or comments? Okay, please.
So very interesting and very elegant talk. I just want to ask that, as you have mentioned, that adenosine or nitric oxide, they also have some effect when used in acute MI as a vasodilator. Adenosine, you mentioned that segmental. What has nicurendil been used? Because that is one drug which we mostly use in Japan. You also use it quite a bit here. So is there any data available? How does nicurendil in this situation behaves? Do you have any observation of nicurendil?
Well, the adenosine effect is not so clear, and because intrinsic ischemia produced a lot of adenosine, even in ischemic heart. So additional administration adenosine is good or not, no bad. But anyhow, how much additional effect is depend on the dose, and depend on the timing, and depend on the reperfusion is done or not. So these factors are very important. And in this trial, there are relatively large dose, but large dose, sometimes hypotension or bradycardia is the side effect. So it's a balance of the efficacy and adverse effect.
With regard to the ischemic remodeling, we have two groups of patients. One is who have infarcted myocardium. Other group, they have ischemic without infarcted myocardium. So do you see the remodeling difference in infarcted versus ischemic myocardium?
Well, it's a very, very tough questions, and maybe no one can answer your questions. I show that it's a very clear case that a myocardial infarction. So the myocardial infarction is a definite entity. And another, cardiomyopathy due to the myocardial ischemia is a little bit different. So in the large trial for the heart failure, it's include more than 50% in ischemic origin cardiomyopathy. So I think it's a little bit different from these entities, but I cannot say what is different and what is, so which drug should be treated, or I have no idea.
And do you see patients who have infarction, scarred myocardium? Normally they should develop dilatation, but there are certain patients who, despite having a scarred myocardium for years, but yet do not develop dilatation of the ventricles.
This is probably the raised phase of the remodeling depends on the apoptosis of the cell. It's much more involved. And I talked today is less than 1 month. That means ischemic insult. That means myocardial infarction. And the remote area responded to this one. And cardiomyopathy later phase is maybe some more complicated, or some response, or the compensation, or some many factors that the complex network. It's very difficult to define the pathophysiology of the heart.
Last question.
Thank you very much, Dr. Gabriel from Sudan. I am very much interested in this nice lecture. I've got 2 questions. What the role of statins in remodeling of the heart? The first question. The second question, in the guidelines, they said that you have to give beta blockers and AC inhibitors immediately in the CCU. I want to know about this one.
Well, the statins law is still controversial, but it is not a definite answer. Statins is good to reduce the mortality of the ischemic heart. However, statin is, as you know, the coronary obstruction of the coronary sclerosis is quickly, depressed. This is one. And another one is the statin is very anti-inflammatory effect. So anti-inflammatory effect sometimes is very good for resolve the, avoid the reactive oxygen species damage. So it might be possible, potential, but it's not clear evidence to. And the second question is the beta blocker and the early phase in the CCU, and there is one study, intravenous beta blocker. It is not good for the mortality of the patients. So the AC inhibitor, intravenous AC inhibitor, consensus 2 trial is failed to get a good answer. So immediately after administration is not necessary, but within a couple of days after myocardial infarction, you should start AC inhibitors, and if possible, the beta blocker.
Thank you very much, Professor Hori, once again, for the excellent contribution.